So we are most appreciative of the support and engagement of O'Connor Mortuary, and they sponsor a great many of our educational webinars. And they are colleagues, they are friends, and some of us have actually had family members or close friends who have been served by O'Connor Mortuary. And the family has been providing mortuary care services for over 100 years. They're family owned and operated. They are expert in all faiths and cultures. They do their best to have always transparency in pricing. The surroundings where people can make arrangements or hold services in their facility are beautiful and elegant and very comforting. And they really have an extraordinary commitment to the community, not only to the families that they serve, but to the community at large, especially the senior care community. So thank you to Becky Lamaka and Joe Fitzgerald. We certainly appreciate your engagement with us. So today we're going to be talking about, are you good to go? And I think those of you that shared a little bit about why this is important to you understand that this really is a personal impact kind of thing when we're all facing our mortality a little bit more closely in light of COVID. But we also want to make sure that the people we serve are prepared in the event that either something maybe catastrophic happens with their health. But now with this specter of COVID hanging over all of us and all of the people for whom we provide care, it becomes even more important to have had some of these discussions way upstream, because none of us want to be making these decisions as we're dialing 911 for somebody that we love. It's really very important. So we'll start, and I just want you to think about the fact that nobody gets to leave this planet alive unless you're an astronaut. So this program was born initially from a starter grant from the Coalition for Compassionate Care, the people who brought the POLST document to California. And that grant first went to Monarch Healthcare. And Dr. Vincent Nguyen, who was medical director there at the time, started up this program in Orange County to really initially educate healthcare providers and hospitals and ambulance companies and emergency medical services about the use of the POLST document. And from there, it kind of mushroomed and grew into a true movement in Orange County. We are now part of the Orange County Aging Services Collaborative, which is a formalized group of about 35 not-for-profit agencies that serve older adults. We have received funding from both the SCAN Foundation and the California Healthcare Foundation, in the past from the Hoag Community Benefit. And as you saw in the title screen, a percentage of my time now is dedicated to this work in community education for advanced care planning. So I'm actually a contract employee of the Hoag Palliative Care Department. So I wear truly two hats, but both Alzheimer's Orange County, which has housed the advanced care planning partners for almost 10 years, and Hoag Palliative Care have worked in a dovetail fashion for more than 10 years. So it's a very natural pairing. But those are all of our financial disclosures. And we enjoy some sponsorship from community partners, as we have today for this webinar. We have a vision, and that is, pardon me, that every seriously ill person receives medical treatments which are congruent with their expressed goals, values, and priorities. But in order for that to really be real and true, people have to express what their goals and values are. We have to ask them, because this isn't something that people will do automatically. It's really something most of us are very reluctant to face. So for 100 years, the Boy Scouts have been telling us, be prepared. Never more than now is it important to be really prepared for not only the inevitable, but for what could be happening in the near future because of these catastrophic problems that we're seeing from COVID-19. It's not smart to hope just that things are going to be okay, because hope is not a good plan. And if everybody just hopes for things to go well, what you have is this collective hoping but no action. So it's really not smart, and we really are asking people to have conversations that nobody wants to have. And even when people are older, and I will give you a little bit more personal disclosure than normal in today's program, because my mother was 97 and we just lost her in April. And up until the time I signed her onto hospice a week before her death, she was reluctant to talk about her POLST document. She says, oh, I don't want to talk about that, as if discussing it would bring it into being. And she was 97. So hope springs eternal, but it doesn't mean that we can miss the event that we all share as human beings, and that is we are going to die. And we have to think about this personally, and we have to think about it in terms of the people that we serve. Because if you're not settled with this in your own heart and soul, and if you don't have peace of mind about what your wishes would be in the event you were very ill or had some catastrophic health event, you're not going to be able to convey the messaging appropriately to the people that you serve. So when I teach classes that train instructors to be able to have these conversations, one of the first things we do is get out an advanced healthcare directive and get out a POLST document. And we play certain games. There's one called Go Wish, where you put out all the things that are important to you or would be important to you if you were facing death, and then we take them away. And so we really have to think about what are our own feelings about death and what kind of care we would find not only adequate, appropriate, but what we would choose if we were in that position. The other thing that's awfully hard for many people is, whom would you pick to speak for you if you couldn't speak for yourself? If I get hit by a bus tomorrow, or if I have a major stroke and I can't communicate, whom would I want making decisions for me? And have I talked to them about it? That's where many families have a big gap. They say, oh, well, my oldest son would take care of that. Have they talked to him? Many times, the person named in an advanced healthcare directive has never been informed. And it happened last year, actually it's now 2 years ago, to a social worker that many of us would know. She had actually worked in hospice care. She had an advanced healthcare directive, and it was locked up in her lawyer's office, very safe. She went on a trip, a little 3-day vacation with her sisters out to the desert. And she came down a flight of outdoor stairs, cement stairs, had a horrible fall and a very traumatic brain injury. So she off to the ER, she had to be put on a ventilator. It was very, very serious. And her sisters looked at each other and nobody knew what to do. And then when her lawyer got back from his golfing trip, hand to God, it's the truth, they were able to get into his office and see her advanced healthcare directive. And it turned out she had named a colleague to be her agent, but she had never spoken with that colleague to tell her that she was the agent. So these sisters, these family members, good friends of this really smart, wonderful social worker didn't know what to do for this person who had worked in this area of care for 5 days until the attorney got back. They could look at the advanced healthcare directive, contact the agent, talk about it. And then they knew that her wishes would be not to be kept alive on a ventilator. But it was pretty agonizing. And it taught me a really clear lesson. And that is, make sure your documents are completed. Make sure you have copies that you have given to all the people who need to know. And make sure you've had some very frank discussions about your wishes with the person that you've named as their agent, as your agent. What would you find acceptable? Now, many people say, oh, I wouldn't want any heroic measures. Well, during this COVID quarantine, when we've had a little extra time on our hands, I've become a Netflix addict of Grey's Anatomy. And I can't even tell you how many times people have said the phrase heroic measures on Grey's Anatomy. What does that mean? What does it mean to you? I know what it means to me, but I have no idea what it means to you. And you can be darn sure that no emergency room staff or ICU staff knows what heroic measures means to you or to your patient or your loved one. Some people would say, oh, heroic measures. Well, that would be being on a ventilator. Well, what if I'm just having some respiratory distress and they think I'm only going to be on the ventilator for 3 or 4 days just to give my lungs a rest? Then it's not so heroic. Well, what about a feeding tube? Oh, that's a terrible heroic measure. I would never want that. Well, except if I had esophageal cancer and I was just going through radiation and I was expected to heal and I had an 80% chance of recovery, well, now the feeding tube doesn't seem so heroic. What about CPR? Well, I don't think I would want CPR. If I had advanced cancer and I was 86 years old and my heart stops, God love me. Send me right to heaven. But I'm 64 today and I don't have a terminal disease. If my heart were to stop, I want CPR today. So our definitions and our wants and our wishes that are congruent with what we hold dear and value are going to change with the situation. But also, it requires conversation because for family members, they may not understand some of the clinical implications of these heroic measures or non-heroic measures, if that's the case. And I have yet to see a family that understands the balance between burden and benefit of treatment until they're actually faced with making this kind of a decision. There are times when caustic chemotherapy and burning radiation is a really, really important part of treatment because the benefit is you have a high percentage of slowing down or eradicating that cancer. There are times when the burden of dialysis is absolutely worth the benefit of having a potential kidney transplant in a month or so. But fast forward to that same patient who didn't get the kidney transplant and now maybe has been on dialysis for 14 years. The burden of the treatment may not balance out the benefits of living under this kind of care. That's a personal decision. But families need to understand that that's the equation healthcare professionals hope to have people balance when they're deciding on some of these really important kinds of care. Well, when should we begin these conversations? Well, in some cases, some people say oncologists don't really want to start end-of-life conversations until they close the casket. It's a little bit of gallows humor, but sometimes that's the case. We don't want to be giving people radiation treatments 2 days before they die. We want people to be able to enjoy whatever life they have left in the way that works for them. So if somebody really wants more radiation, then absolutely it's their choice to have it. But let's start these conversations way upstream at the beginning of a diagnosis. And now more than ever, when we're seeing the cases of COVID-19 start to spike in not only skilled nursing facilities, but in congregate living situations like assisted living, memory care units, boarding care homes, we should be talking with every person in those living situations before they get a COVID diagnosis. Because sometimes people become so ill so fast, we're not able to have a coherent conversation with them. We should know what they would find acceptable if they were to be infected with COVID now. We should know, do they want to be transported to the hospital? Which under the circumstances means they can't see their family, they can't see their friends, and the mortality rate for people over a certain age is very high. Oh, look, Joe Fitzgerald has entered our room. Hello, Joe, how are you? Can you hear us? Okay, I saw that Joe Fitzgerald from O'Connor Mortuary has entered the Zoom room, and we just can't hear him yet.
Hi, Patty.
Oh, there you go.
I am so sorry. I lost the link, and I tried emailing. You got a voicemail from me, and I apologize for being late on.
That's okay. We're underway. Would you like to say a few words of welcome to our group, Joe?
Yeah, welcome everybody. You know, I'm Joe Fitzgerald. I'm the CEO of O'Connor Mortuary, and you know, I've been part of the family working here at O'Connor's for 28 years. I'm actually married to one of the O'Connor daughters. You know, we're really a proud partner of Orange County, Alzheimer's Orange County. And, you know, we're here to provide resources and education in today's class. So we really understand the value of community involvement. And, you know, it's really been our longstanding tradition here at O'Connor. So thanks again for allowing me to interrupt midway through. So.
No problem. Welcome, Joe. We're glad you could be with us. Yeah. So the time to start having these conversations about what people would find as acceptable at end of life is now, and especially with COVID hanging over all of our heads. As we said, hope is not a plan, and 50% of us are not able to communicate what we want in a crisis. 50% are either too sick, they have dementia, they've been injured, they're on a ventilator, they can't communicate. And so our default is to treat aggressively to basically preserve life at all costs, even if that care is extremely burdensome. And even if they wouldn't want the care, if we don't know it and have it in writing, that's our default. And family members notoriously cannot make really considered, measured decisions in the midst of a crisis. It's just too hard. It's do something. We'll do everything. Well, doing something and doing everything may not be hooking somebody up to a bunch of tubes. It might be allowing the person to be very comfortable, allowing their family to be bedside, maybe not even having the person be transported to the hospital. That may be doing everything for that person. And the way we can engineer that is to know ahead of time. I love this quote from Ralph Waldo Emerson: "When it is dark enough, you can see the stars." Sometimes we need a catastrophe like COVID to kind of pull us all up short and think about how we would want things to be if it were decisions being made about our care. You don't want it happening as the helicopter is touching down to put you in and whisk you off to the trauma center. And modalities like this don't work. Even if you tattoo, do not resuscitate on your chest, the paramedics are not going to listen. So if you really don't want CPR, then you have to fill out a POLST document. So that was supposed to be funny. So I can't tell if any of you are laughing. I hope you are. Only 25% of us have actually put our wishes into writing in a form that paramedics and other clinical staff could use and could operate by. That's pretty paltry. And part of our goal in this initiative of the Orange County Advanced Care Planning Partners is to make sure people know what tools they can use, when it's appropriate to have an advanced healthcare directive. Now, does anybody know when it's appropriate to have an advanced healthcare directive? Take a guess. Unmute yourself and guess.
At any age, Patty.
Exactly, over 18. Every person over the age of 18 should have an advanced healthcare directive. That's because the primary goal and the primary use of the advanced healthcare directive is to name the agent who would speak for you. So everybody should have an advanced healthcare directive over the age of 18. And if you don't want to die here, if this doesn't look comforting and lovely and wonderful, then fill out an advanced healthcare directive, talk to your loved ones about it, and when appropriate, complete a POLST form. I don't like to talk about healthcare costs per se in terms of end-of-life care, because I really believe that if somebody has a burning desire to try everything to stay alive, then cost should not be the issue. We should be able to try those things. But what we have to understand is most people who die in ICUs wouldn't want and didn't want the care that they received that was inflicted upon them that ends up costing tens of millions of dollars. A disproportionate percentage of the Medicare budget is spent on care in the last few weeks of life that most people, when polled when healthy, say they don't want. And it doesn't change the outcome. The person that we're talking about still dies. So bad news is tough. So this is one of my favorite slides. I'm going to do it again. Maybe I can't on this. You really want to let bad news sink in. If you are talking to people and it's a time when you're having to help them understand a difficult diagnosis or the importance of completing a POLST document because they are closer to terminality, you have to do it in such a way that gives them time, balance, and the opportunity to let the room and the world spin out of control for a while and then come back to it. Most professionals in the hospital who have to help people fill out POLST documents while the patient is hospitalized will tell you it's not a one-time conversation. It's not a 1 hour or a 2 hour conversation. It's sometimes where you have to go back 2 or 3 times, where you really have to give somebody the opportunity to let all of this settle, and then they can start to think clearly. Nobody's going to argue with you if you say, take a deep breath with me. So if you're ever faced with a situation where you have to share very bad news with a patient, with a family, breathe and just say, let's just sit down and take a deep breath together. Let's just walk through this and we can go slowly. And sometimes that helps to bring down the tension, calm the emotions. We know it helps to settle down the heart rate, change the pH of our bloodstream, oxygenate. It helps thinking. And if people are starting to get really upset, they won't refuse to just breathe with you. So these are the two documents that we talk about most. The 5 wishes is an advanced healthcare directive. Now in California, there are more than 150 instruments that can serve as an advanced healthcare directive. And they're all legal, provided they're signed properly, witnessed, and dated properly. They do not have to be notarized. And most people are kind of surprised when they hear that an advanced healthcare directive does not require a notary. It doesn't, can't hurt, but it's not required. It has to be signed by the person for whom the advanced healthcare directive is being completed. So if it's mine, I have to sign it, I have to date it, and then 2 people who are not engaged in my care, and preferably not any relatives, have to witness that they know me, they know my signature, and they're pretty sure I'm not being coerced into doing this. So the Advanced Healthcare Directive names the agent that speaks for you in the event you can't speak for yourself. The power in this document does not attach unless you cannot speak for yourself. So let's say I complete my Advanced Healthcare Directive now, which I have, and 20 years from now, I develop Alzheimer's type dementia, and everybody knows I have lost capacity and I can no longer sign any new documents. Well, that document now attaches. Now the person that I have asked to make decisions for me can make them in the event I can't speak for myself. Medical decisions, it's your agent, becomes your healthcare agent, okay? The POLST document is kind of a next step from an advanced healthcare directive. These two don't cancel each other out. They are they're complementary, so they work in concert. And you do want to have both documents, because in my 5 wishes, I might be telling Joe at O'Connor that I want to have no carnations at my funeral, and that I want only popular music from the last 10 years played on that organ, and that I don't want my Aunt Cecilia to sing, and that I want to be buried in a sunny spot under a tree. Wishes for the future, for future care. And in here I might have said, I don't want heroic measures performed. Well, again, how did I define heroic measures that day? And how would I define them later on? And does my agent know what I mean when I say heroic measures? In my case, my agent is not my adorable husband. Many of you know him. He is maybe the nicest guy on the planet, and we've been married for 32 years. He is not my agent. Because if he were sitting at bedside after I'd had a catastrophic brain injury, and I'm on a ventilator, and they've done codes on me 2 or 3 times, and they're telling him there is no hope of recovery. In fact, some of them want to be talking about organ donation. He'd be sitting bedside, and if my hand twitched, he'd say, she's coming back, she's getting better. So my agent is my daughter, who is a registered nurse and has been for 15 years. She's not one of those really nice nurses. She's not really a sweet, warm, cuddly kind of a nurse. She's the kind that says, hold still or it's gonna hurt, and she means it. She's very pragmatic, and she understands the clinical side of life and end of life. And so she's my agent, because she could look at all the clinical data and she could say, Mom, it's been lovely. And then she could allow natural death. And that's why she's my agent, because my husband would be the one to say, oh, do something. When the do something that I would want is not to be in an ICU when I die. My do something, my do everything would be to be at home in my own bed with my little dog and a couple of grandchildren and my husband, playing some Joni Mitchell music and maybe even having a cup of tea or a Jameson's, but not in an ICU. That would be do everything for me. So our task as people are filling these out is to help them understand, what does do everything mean for you? What does your perfect death look like? It's hard to think about. We're a death-defying culture. So for those people who are in a position clinically where no one would be surprised if they died within a year, or at very advanced age, or chronic serious illness, then a POLST becomes appropriate. Now, in this time of COVID, let's say you have an 87-year-old who has a little COPD, survived a heart attack a year ago, but has a pretty good prognosis from a recent hospitalization for a knee replacement. That person might need a POLST. And if you pepper the whole equation with COVID, when they're recovering in a skilled nursing facility that has had an outbreak of COVID, it becomes even more important because the potential for them to be infected is very high. So we'd want to know, yes, of course we want you to get better. Yes, of course we want you to do the physical therapy for your knee. Yes, of course, our plan is for you to be up and back on the golf course in 6 weeks. But what if? And so where we might not ordinarily insist on a POLST document for somebody who's having a knee replacement, now in the time of COVID, we have to look at, what is a person's risk? What kind of living situation are they in? And what would they want if all of a sudden they became ill very quickly and we had to make very fast decisions about their care? And that's what the POLST can do for them. So this is a black and white copy. The POLST is usually bright, obnoxious Pepto-Bismol pink, and that's so that it stands out, so that it's easily recognizable. And the paramedics are trained to look for a POLST either on the back of a door in a congregate living situation or on the refrigerator if somebody's living in their home in the community. And it allows for people to very, very directly talk about what they would want in given situations. So if we come upon you and you have no pulse and you're not breathing, well, if you come upon somebody who has no pulse and is not breathing, what would we call them? Dead. So cardiopulmonary resuscitation is not magic. It's not like the fairies in Sleeping Beauty coming and doing fairy dust and making the sleeping princess come back immediately. Cardiopulmonary resuscitation, CPR, is violent. It is very aggressive, and it doesn't work nearly as well in real life as it does on Grey's Anatomy. So I used to give this talk, I don't know, 8 or 10 years ago, and then I was watching ER. And Dr. Nguyen very, very poetically put it one time that if you have cardiac arrest and they bring you back in the hospital with CPR, 30 minutes later, before the end of the episode, you are not going to be having a cheeseburger and a beer with George Clooney. I don't care how cute you are. It doesn't work that way. So CPR is violent, and it doesn't work the way we think it does. The results of CPR are sometimes very disappointing. And if someone is over 65 and has a cardiac arrest in the hospital and they call the code blue and bring in the crash cart, a very low percentage of those people actually live. Even fewer live to discharge from the hospital, and even fewer live to regain their same level of functionality that they had before the cardiac arrest in the hospital. So it is not a panacea, but it can work. And today, if I fall over with cardiac arrest, especially if I've been hanging Christmas lights and I stick a bobby pin in one of the sockets to get out the broken bulb, please, somebody do CPR on me, because I might very well be brought back. But I also might not be brought back to my level of functionality. I'm kind of at that borderline age, kind of a tipping point. So CPR is the first decision on the POLST. Attempt CPR or do not attempt CPR and allow natural death. If you check, I want you to attempt CPR, then you must have full treatment in section B, because we wouldn't bring you back and then do nothing. So if you say you want CPR, then you have to have advanced cardiac life support. That means you get put on a ventilator 9 times out of 10, and other things start to happen. So it's important that people understand that, and that that's kind of a trigger point. In section B, let's say I've chosen do not attempt CPR. Well, I might want full treatment for a period of time, for a trial period of time. Maybe I've had a bad brain bleed, but they think I might get better and they're going to put in a shunt and relieve the pressure. And maybe I have to be on a ventilator. Well, maybe for a trial period, maybe just for a week. Because after about a week, then a decision has to be made about the ventilator as to whether or not it's going to be surgically inserted in my throat. So we have to be honest with people that it's not as romantic and poetic on TV as it is in a real life ICU. Selective treatment, where maybe the goal is treating my medical conditions, but avoiding terribly burdensome kinds of treatment. Maybe I want IV antibiotics for my infection, but I don't necessarily want to be intubated. Maybe I want non-invasive positive pressure, like a CPAP machine or a BiPAP machine. And maybe I don't want to be transferred back to the hospital. Maybe I want to be able to stay in my own home. And then maybe I only want comfort-focused treatment. I just don't want to be in pain. If I have an infection that's causing pain, well, you could treat that, but I don't want all kinds of extra things done to me that maybe are not going to change the outcome and are just going to prolong my death event. So there's an opportunity to choose comfort-focused treatment. Other decisions that need to be made include artificially administered nutrition and hydration. Now, so many families struggle when a patient can no longer take in food and fluid enough to sustain life. And this is particularly poignant when people are facing end-stage dementia, because part of the whole dementia syndrome and disease progression is that we forget how to swallow properly. And if we do ingest or imbibe, then we have a very high risk of aspiration pneumonia, which is not a good thing for people who are very, very compromised. So we have to think about the fact that in most situations, if someone is unable to ingest or imbibe food and fluid, it's probably because their disease has progressed to a point where their body is just slowly, slowly, slowly preparing them for exit from this life. They're not starving to death if they're at end-stage cancer. They're not starving to death if they're at end-stage dementia. And most other serious chronic diseases where people are reaching that end stage, getting closer and closer to death, they're not craving food, and their body probably can't process it anyway. So it's not always smart to now introduce artificial fluid or put in a tube for feeding. Sometimes it causes more problems than it attempts to solve, and the body can't process it, so you have swelling issues or infection issues. You do want to have appropriate signatures here. Now, if I become incapacitated before I have completed my POLST, if I have clearly identified my wishes to my agent in my healthcare directive, my 5 wishes, then my agent could sign my POLST, knowing my wishes. If I haven't completed an advanced healthcare directive, but I have a very dear friend who can attest that my wishes would be for certain kinds of care, then that interested party can sign my POLST. So it's a little different than an advanced healthcare directive. So signatures are important, and in order for this to be valid, it must also be signed by a clinical professional, a physician, a nurse practitioner, or a physician's assistant. And if the patient can sign, then the patient should sign, or a legally recognized decision maker, which does not have to be the same person named in their advanced healthcare directive, but it's better if it is. And the back is logistics, but it is always, always, always voluntary to complete a POLST document. So when you're working with people in skilled nursing facilities, a common misconception and mistake of the skilled nursing facility is to make everybody sign a POLST, even if they're just coming in for recovery from joint replacement surgery. Now, with COVID, this may not be a bad idea. Without the specter of COVID, it was sort of thought to be really bad practice. But now that COVID is hovering over all of our healthcare, it may not be such a bad idea to at least have a discussion. But it's not a 10-minute, here, sign, check this box. This takes some time, and then it must be validated by a clinical professional, licensed clinical professional signature. So a quick comparison is the Advanced Healthcare Directive is for anyone over 18. Everybody should have one. Really important. Your kid goes away to college. If they get in a bad accident, you want to be sure you as the parent are their agent, because otherwise that 22-year-old senior that they had lab with, that they got to be really good friends with and moved in together but haven't told you yet, and that person brings them to the hospital, you could have that 22-year-old or 23-year-old that your child has known for all of 6 weeks making medical decisions for your child. So Advanced Healthcare Directive for everybody over 18. The POLST for people who are seriously ill, have serious chronic disease, they're frail, they don't have to be old. Although, if somebody is of advanced age, and no one would be surprised if they died within a year, then a POLST is appropriate. The Advanced Healthcare Directive gives general instructions for something that might happen in the future. And again, sort of amorphous things like heroic measures, or don't keep me alive artificially, or no carnations at my funeral. But the POLST gives specific clinical direction for treatment that could happen today. And the Advanced Healthcare Directive's primary work of this instrument is to name the medical decision maker. But the POLST could be signed by the decision maker. This document was enacted by statute in 2009. It's been updated several times, and about every 4 years or so, we get a new iteration, and we're about due for one now. But again, for people who are seriously ill or very frail, It must be signed by a doctor, a PA, or a nurse practitioner. The pink is to distinguish it, and it is recognized as a legal medical order by emergency medical services, emergency departments, and across all healthcare settings. And like all important legal documents, both your Advanced Healthcare Directive and your POLST should be reviewed, because today I might want my daughter to be my agent. But what if 5 years from now we're fighting over an inheritance and we're estranged? I don't want her to be making decisions about me, because she might send me off to Valhalla a little too quickly if she thinks she's going to inherit that $10 million. So think about it at least every 5 years, and certainly if there's any major health or life events. This is one of the most important qualitative tools for determining whether or not a POLST is appropriate. Would you be surprised if this patient died within the next year? And if the answer is no, then it's appropriate for that discussion to be held. Again, in light of COVID, anybody who is at serious risk and in that high risk category of people who are older, who have lung disease, who have any comorbidities that could be exacerbated by COVID, then we may want to have a POLST discussion with them. And it requires this conversation with a healthcare provider. Someone like me, or a chaplain, or a social worker could help someone complete their POLST, but there still needs to be a conversation before that licensed clinical professional signs it and makes it a legal medical order. And it's very exact wishes. And as I said, it has to be signed. What happens if there's no advance directive or no POLST? Well, I alluded to it. It could be the nosy neighbor who follows the ambulance, who says, oh, I'm your best friend. I've lived next door for 32 years. Maybe I don't even want her to know I'm sick. But if she's the loudest one in the emergency room, they're going to listen to her. So make sure you've made those wishes known. And a really smart thing to do is have your Advanced Healthcare Directive, and if appropriate, your POLST on electronic file at the hospital where you're most likely to be taken. So part of our job is to do lots of education here in the community to help people understand what these instruments are for, how to get conversations started. And we'll go just about anywhere. We go to churches, we go to universities, we go to nursing schools, medical schools. I go to Rotary clubs. Any place you want us to go, we're likely to say sure. I'm also not opposed to using smart, cute little girls in pink suits to advertise the POLST document, or tall, beautiful blondes. We do that too. And when the POLST documents come in, we all get really excited. But we really want people to make choices ahead of time, because this lady was asked so many times for her Christmas cookie recipe, and she said, over my dead body. So instead of protecting her recipe, this is what happened. So prepare ahead of time. You also want people to have an opportunity to say important things to the people that they love. And this is from Dr. Ira Byock. When you initiate these kinds of conversations about decisions in care, you give people the opportunity to say thank you, to say I love you, I forgive you, please forgive me, and goodbye. And in the time of COVID, this becomes so important that we're saying these things to the people we love every day. Every time they go out to the Stater Brothers Market, we should be saying these things, because how many people have stories about their loved ones being whisked off to the hospital and they never see them again? Yes. So this dark cloud of COVID is giving us some really important nudging to not only get these documents completed, but to be a little more open and frank with our loved ones and to say the things that are most important. So we're finishing up just about right on time. I can take a few questions, but we encourage you to contact us. We encourage you to have people talk about these things. And if you want copies of either the 5 wishes or the POLST document, you can email us and we will send them to you via US mail. So thank you. It has been my pleasure to talk with you.